Okay. So today we are going to study about smoking and periodontium. These are the contents which we will cover under this PPT. Starting with the introduction part, smoking is associated with a wide spectrum of disease, including stroke, coronary artery disease, peripheral artery disease, gastric ulcer, and cancers of mouth, larynx, esophagus, pancreas, bladder, and uterine cervix. It is also a major cause of chronic obstructive pulmonary disease and also a risk factor for low birth weight babies. Approx 50% of regular smokers are killed by their habit, and smoking causes 30% of cancer death. Coming to epidemiological evidence. So there are many cross-sectional and case control studies which demonstrate moderate to strong association between smoking and periodontitis. And this is according to Hill's criteria. You will see there are smokers which are 4 times more likely to develop periodontitis as compared to non-smokers. Smoking may be responsible for more than half of the periodontal disease among adults. And according to McFarlane et al. In 1992, he found that up to 90% of refractory periodontitis patients are mainly smokers. Coming to the next slide. So, here in the year 2000, Bergstrom et al., he found that he conducted a 10-year prospective study of smoking and periodontitis, and he found that smokers lost more periodontal bone as compared to non-smokers. Okay, coming to the next topic, age, sex, and cigarette smoking under smoking and periodontitis. So in Carranza, it is stated that women from age 20 to 39 and men from age 30 to 59 who smoke cigarettes, they have twice the chance of having periodontal disease or becoming edentulous as compared to non-smokers. The effects of smoking on periodontal status is more pronounced in younger women, and this was according to Goudston et al. In 2010. So here is the graphical representation of uh, change in prevalence of tobacco use in India. See, you can see here, these are the graph of tobacco users, smokers, and smokeless tobacco users. So how it is uh, representing prevalence of tobacco use in India. And this the percentage distribution of adults by tobacco use. Okay, so now there are many different methods of tobacco smoking. It includes cigarettes, cigars, beedi, pipes, hookahs, and passive smoking. Next is the classification of smokers. So it is mainly divided into heavy smokers and light smokers. Heavy smokers are mainly those who smoke 20 or more than 20 cigarettes per day, whereas light smokers are those who smoke 20 sorry less than 20 or equal to 19 cigarettes per day. Then it is again divided into current smoker, former smoker, and non-smoker. Current smoker, those who have smoked 100 or greater than 100 cigarettes per day, sorry, in their lifetime and currently smokes. Former smoker who have smoked 100 or greater than 100 cigarettes in their lifetime and do not currently smokes. And non-smoker are those who have not smoked 100 or greater than 100 cigarettes in their lifetime and they do not currently smokes. Many smokers are trying to quit and therefore simply asking how many cigarettes they are smoking today may not give an accurate assessment of their lifetime exposure. So to get around this problem, pack years was calculated. Pack years, how pack years is calculated? Here is the formula by which we can calculate pack years. Pack years is equal to number of packs smoked per day multiplied by number of years of smoking. Okay, coming to the next slide, constituent of tobacco smoke. Cigarette smoke is a very complex mixture of substances with over 4,000 known constituents and comprises of two phase, gaseous phase and solid phase. Gaseous phase includes carbon monoxide, ammonia, formaldehyde, hydrogen cyanide, acrolein, benzopyrene, and dimethyl nitrosamine. Whereas the solid particulate phase, the main constituents are nicotine, tar, benzene, and benzopyrene. So this all constitutes cigarette smoke. Okay, mainly it is of two phases, the gaseous phase and the solid phase, in which solid phase you have nicotine, tar, benzene, and benzopyrene are the main constituents, whereas in gaseous phase all the gases, carbon monoxide, ammonia, formaldehyde, hydrogen cyanide, and all. Okay, so this is the table of constituents of cigarette smoke. So these all substances which are in gaseous phase or in particulate phase, their main effect is mainly carcinogen. They all are carcinogens. In gas phase, you will see carbon monoxide, it impairs oxygen transport and utilization. So mainly 90% of these substances, their main effect is they are carcinogens. Okay. Coming to solid or particulate phase, in which we have nicotine, tar. Okay. So tar in its condensate form, it is a sticky brown substance that stains fingers and teeth yellow brown. So whenever patient comes to you with stains which are yellow brown and has the habit of smoking, so it is mainly because of tar. Tar is the reason behind it, which causes stains and teeth yellow brown. Okay. The next is nicotine. Nicotine is an alkaloid found within tobacco leaf and evaporates when the cigarette is lighted. It is quickly absorbed and reaches the brain within 10 to 19 seconds. Nicotine in tobacco smoke from most cigarettes, it is not well absorbed through the oral mucosa because it is in an ionized form. Whereas in cigar and pipe smoke, you will see it is it is quickly absorbed because it is in unionized form. So nicotine in tobacco smoke is in an ionized form, and in cigar and pipe smoke, it is in unionized form. Nicotine is absorbed rapidly in the lung where the smoke is well buffered. It is highly addictive and it causes rise in BP. It causes increase in heart rate, respiratory rate, and peripheral vasoconstriction. So there was a study by Benowitz in 1989 found that tar and nicotine yields reduced due to use of filters, and dose of tobacco intake depends on the way an individual smokes. So these two are the main constituents of tobacco smoke or of solid phase. Okay. Now, assessment of smoking status. So, how will you come to know about the patient's exposure to tobacco smoke? The patient's exposure to tobacco smoke can be measured in a number of ways, including interviewing the subject using simple questions or more sophisticated questionnaires and biochemical analysis. So, mainly three procedures are there in which you can assess the patient's exposure to tobacco smoke. Coming to the first method, which is biochemical analysis. Okay. So first method is biochemical analysis. In biochemical analysis, how will you measure? You will measure the exhaled carbon monoxide in the breath, which is mainly measured in smoking cessation clinics. Cotinine, you can measure it in saliva, plasma, or urine. Cotinine measurements are more reliable in determining subjects exposure to tobacco smoke. Why? Because their half life is 14 to 20 hours as compared with the shorter half life of nicotine. So half life of nicotine is only 2 to 3 hours, whereas half life of cotinine is 14 to 20 hours. The mean plasma and salivary cotinine concentrations of regular smokers are approximately 300 Ng per ml, and urine concentrations are about 1500 Ng per ml. Non-smokers typically have plasma or saliva concentrations under 2 Ng per ml, but this may be raised due to environmental exposure. Okay. So you can see cotinine measurements are more reliable than nicotine measurements. Okay. Now, how tobacco smoking affects all the oral tissues. First, we'll see one by one its effect on plaque and oral flora, periodontal tissues, homeostasis and healing potential, periodontal therapy, and immune response. Coming to the effect of smoking on plaque. Okay. Effect of smoking on plaque. So, in plaque, you will see mainly effect on periodontal pathogens. So, you can see higher proportion of A. actinomycetin comitans, P. gingivalis, T. forsythis in smokers. And it was found according to Zamban et al. In 1996. You will also find increased count of exogenous flora like E. coli and Candida albicans. And mainly orange and red complex pathogens, they are more prevalent in current smokers. They have more orange and red complex periodontal pathogens. So smoking also affects salivary flow. How? It is easier for oral microbes to stick to teeth and gingiva. Why? Because smoking reduces salivary flow. So it becomes easier for microbes to stick to teeth and gingiva. Even smokeless tobacco products can irritate gingiva, causing it to loosen around teeth, making it easier for bacteria to settle and develop calculus. So these are the effects of smoking which you will find on plaque of smokers. Smoking. Okay. Smoking and host response. Smoking decreases salivary IgA and serum IgG, and it reduces IgG to levels against actinomycetin comitans. And the ability of tobacco products to decrease proliferating capacity of T and B lymphocytes, it also contributes to the diminished production of antibodies. Okay, so the tobacco products, what they do, they decrease the proliferating capacity of T and B lymphocytes, which ultimately leads to lesser production of antibodies. Smoking can also exert deleterious effects on polymorphonuclear leukocytes and other neutrophil functions. What are the other neutrophil functions? Chemotaxis and phagocytosis. So they, because of the effects on its functions, it cannot function well. It cannot function in a proper way. So they cannot deal with bacterial infection. Okay. So, according to McFarlane et al. In 1992, impaired phagocytosis function of neutrophils among smokers. It was found in refractory periodontitis cases. Smokers with refractory periodontitis cases, in their neutrophils, impaired phagocytosis function was found. In addition, tobacco smoking may modify the production of pro-inflammatory cytokines and TNF alpha, which are these two are the key regulators of host response to microbial challenge. So it also modifies their production. So this is how smoking alters the host response. Tobacco use in all forms, especially cigarette smoking, it is the number one risk factor for oral cancer. So here are the possible mechanisms. These are irritants and toxic substances which are present in tobacco. Their change in pH, change in immune response, dryness due to heat produced, which is dryness, which is due to heat production while smoking. The decreased subgingival temperature. The most common form of cancer is squamous cell carcinoma, as you all know, and their common sites are tongue and floor of mouth. The other common sites may be buccal vestibule, buccal mucosa, gingiva, hard palate, and soft palate. Cancer of buccopharyngeal mucosa is common in smokers. So here are the pictures in which you can see clinical changes seen at site of involvement. Carcinoma, leukoplakia, erythroplakia, dysplasia, and carcinoma in situ. Whereas here are the other lesions in which it is smoker's palate, smoker's melanosis, hairy tongue, and coated tongue. So these are the clinical pictures. Okay, so this you can see clinical changes at site of involvement. Dental caries and erosion. Smoking, what it does, smoking stimulates saliva flow immediately and does not affect saliva on long-term basis. It decreases pH and buffering action. It immediately stimulates saliva, leading to decreased pH and buffering action, which leads to dental caries and erosion. Okay, coming to the next effect of smoking on gingiva. So effect of smoking on prevalence and severity of periodontal disease, in which we'll see effect of smoking on gingiva. So in gingiva, you will see the changes in the gingival epithelium. It becomes hyperkeratotic, hyperplastic. There is grayish discoloration of gingiva seen. You'll see increased amount of interleukins and prostaglandins. Effect of smoking on gingival blood flow. So here we saw about the changes in epithelium, the grayish discoloration of gingiva, and increased amount of interleukins and prostaglandins. Coming to the effects on its blood flow, gingival blood flow. So you'll see in smokers, gingival blood flow was significantly increased by cigarette smoking. However, IV administration of nicotine reduces marginal temperature of gingival sites, suggesting decrease in gingival blood flow, which leads to hypothesis that this phenomenon is caused by vasoconstriction induced by nicotine and stress. Oxygen tension in gingival tissues. Smoking decreases tissue oxygen. Tissue oxygen decreases while smoking. So mainly it reduces to 44 plus minus 3 mmHg. And tissue oxygen, when it becomes around 40 to 50 mmHg, it leads to infection. Effects on gingival vasculature. Researchers found a high proportion of small vessels as compared with large vessels, which were seen in smokers rather than non-smokers, but there was no difference in its density. Coming to the evidence from studies which were seen on GCF flow rate. Okay, effects on GCF. So smoking may result in lower resting GCF flow rate. The increase in GCF during experimental gingivitis may be less in smokers. Studies have shown higher level of TNF alpha and decreased level of IL-1 alpha, matlab interleukins, and um, enzyme elastase in GCF when compared with smokers and non-smokers. Also, there was a research in which it was demonstrated that there was lower level of cytokines, enzymes, and PMNs in GCF. So this correlates with the lower level of inflammation observed in smokers clinically and also within the tissues. Okay, so it was found that smoking has lower resting GCF flow rate, plus it has lower level of inflammation, which was observed clinically and within the tissues. And why? Because of this reason. Okay, coming to gingival fibroblasts. Gingival fibroblasts, you will see mainly there is reduction in type 1 collagen and fibronectin, and there is increase in collagenase activity. Cellular changes like cell orientation, changes in cytoskeleton, presence of large vacuoles, and significant reduction in cell viability have been noticed. Smoking and gingival inflammation, we have already read. Smokers present with lower level of inflammation than non-smokers. Furthermore, development of inflammation in response to experimental plaque accumulation was less pronounced in smokers as compared to non-smokers, and it was by Albender et al. Coming to the periodontal fibroblast. Periodontal fibroblast growth, attachment, and integrin expression. It was all inhibited by nicotine at high concentration. So nicotine at high concentration, it was found to be cytotoxic. What it does, it inhibits proliferation of fibroblasts. PDL cell proliferation and protein synthesis were also inhibited in a dose-dependent manner. Cell attachment, it was less on root surface obtained from heavy smokers compared with non-smokers. So these are all studies which was done to see the effects of smoking on periodontal tissues. Smoking and periodontitis in young adults. Several studies have shown young adult smokers aged between 19 to 30 years, they have higher prevalence and severity of periodontitis as compared to non-smokers despite lower plaque levels. The prevalence of periodontitis defined as having a side with attachment loss of 2 or greater than 2 mm and probing depth of 4 and greater than 4 mm. It was 4 times higher in smokers compared to non-smokers. Smoking and periodontitis in adults. Current smokers, they have deeper probing depth, greater attachment loss, more bone loss, and fewer teeth. Smokers also exhibit more supragingival calculus deposit, and they are 4 times more likely to have periodontitis as compared to non-smokers. There is a strong dose response relationship between amount smoked and severity of periodontal destruction, which supports the role of smoking as a risk factor for periodontitis. And the most marked difference between smokers and non-smokers in probing depth occurs in the maxillary lingual area or mandibular anterior area, which suggests a local effect of smoking. Here is the picture in which you can see how difference is seen between smokers and non-smokers. Then coming to effect of smokeless tobacco on periodontal tissues. It involves chewing a liquid that includes betel leaf, lime, areca nut, and tobacco. Tobacco use may increase bleeding on probing and periodontal attachment loss. Other studies have shown that the negative effect of areca nut on host immunity by affecting PMNs. Arecanut extracts also inhibit growth, attachment, and matrix protein synthesis of human gingival fibroblasts. So all these are the effects of smokeless tobacco. Coming to smoking and anug. Smoking and anug, so there is a strong association between necrotizing form of periodontal disease and tobacco smoking. Here is the flow chart in which you can see how smoking leads to onset of NF. Smoking, it influences the tissue response to irritation, which activates the release of epinephrine. Then it leads to promotes contraction of peripheral vessels, also reducing blood flow to the gingiva, which leads to loss of vitality to the gingival epithelium, and here is the onset of NF happens. So this flowchart is very important, in which you can see how smoking leads to onset of NF. Immune inflammatory response. So first of all, its effect on PMN function. Smoking exerts major effects, like it mainly has an effect on neutrophil. Neutrophil, its important role is in chemotaxis, phagocytosis, and also it kills oxidative and non-oxidating mechanism. Then again, there were studies in which it was seen that nicotine exposure increases secretion of prostaglandins by monocytes in response to lipopolysaccharides, resulting in more periodontal destruction. Antibody production was reduced, which is essential for phagocytosis, and the levels of immunoglobulins were reduced. So you will see nicotine impairs release. Nicotine impairs elimination of periodontal pathogens by inhibiting release of neutrophils, which results in oxidative stress tissue damage. Impaired PMN function may also contribute to increased risk for periodontitis in the later life. Okay. Um, Coming to smoking and lymphocytes function. So mainly you will see immunosuppression. Here, you can see the flow chart. The leukocytes observed in smoker results in increased number of circulating T and B lymphocytes. Chronic exposure to nicotine. What it does, it impairs antigen-mediated T cell signaling, which leads to inhibition of antibody cell response, and it leads to immunosuppression. So these were all the results found by various studies done by various authors. You can see cytokines. Elevated level of TNF alpha have been demonstrated in GCF of smokers. Also prostaglandins, MMPs, these were all elevated in GCF of smokers. So in vitro studies have shown that exposure to nicotine increases secretion of prostaglandins by monocytes in response to lipopolysaccharide. So all these factors which we have read till now leads to suppression of normal inflammatory response. Here's the table how you can see in this we have already read about the microbiology, about the immunology, and about the physiology. And here is the impact of smoking. Effects of smoking on response to periodontal therapy. So first we'll go with the non-surgical therapy. In non-surgical therapy, you'll see decreased clinical response to scaling and root planing, decreased reduction in pocket depth. There is no gain in CA. There is also decrease in negative impact of smoking with increase in level of plaque control. In surgical therapy and implants, you will see There is no increase in pocket. There is no decrease in pocket depth reduction post surgery. You'll see deterioration of percussion, and there is a decreased gain on clinical attachment level, decreased bone fill. Okay. Whenever GTR therapy is done in smokers, so you will see decreased pocket depth reduction after grafts, decreased pocket depth reduction and gain in clinical attachment level after flap surgeries, and there is also exist conflicting data on the impact of smoking on implant success. So smoking cessation should be recommended before implants. Whenever you go for implants, ask the patient to quit the habit of smoking. Coming to the maintenance therapy, you will see increased pocket depth during maintenance, decreased gain in cal, and you'll see more residual pockets where more deeper pockets will be present after flap surgery. In refractory cases, there are many refractory cases which are increasing in smokers. Increase for retreatment in smokers, you'll again have to go for treatment and again treatment. Increased need for sorry increased need for antibiotics to control the negative effect of periodontal infection, and there is also increase in tooth loss following surgical therapy. Okay, now coming to tobacco cessation. Effect of smoking cessation on periodontal disease outcome. The periodontal status of former smoker is intermediate to that of current smokers or non-smoker and appears to be closer to that of non-smoker. One who quits smoking had better response to periodontal treatment as compared to non-quitters, those who did not quit. The benefits of smoking cessation is likely to be mediated through various pathways, such as you will see there is a shift towards less pathogenic microflora. You will see gingival microcirculation gets recovered, and there is also an improvement in immune inflammatory response. Okay, so here are the 5A. 5A, which you have to remember whenever you go for smoking cessation. These 5A to intervention, these 5A to intervention stands for ask. Ask about the tobacco use, advise the patient to quit, assess willingness to make a quick attempt, and assist in quit attempt. Sorry. And arrange for follow-up. So these are the 5 A's which you have to remember whenever you go for smoking cessation plan. Ask, advise, assess, assist, and arrange. So there were various approaches in smoking cessation. Increased tobacco taxation and counter marketing campaigns. You can you make use of counseling and pharmacotherapy. Various medicines are also available, like nicotine in that increase long-term smoking cessation. These are nicotine inhalers, bupropion, lozenges, nicotine patches, gums, and nasal sprays. First line medications are nicotine gums, inhalers, lozenges, and patches, and second line medications are clonidine, nicotine spray, and nortriptyline. According to WHO guidelines, more than one type of pharmacotherapy should be offered in combination, like if you go for a prolonged period. Then you can also make use of mass reach health communication intervention like television, newspapers, billboards. So all these methods can be used in smoking cessation. Quit lines can be used as phone-based service, like you can make use of caller tunes for stopping smoking. You can go for tobacco cessation programs, which can be custom made depending upon income and educational status. Then comes NRT. NRT is what? Nicotine replacement therapy. What is NRT? Nicotine replacement therapy is, it involves use of other nicotine substitutes, and it relieves withdrawal symptoms by delivering small doses of nicotine into your body. It involves use of gums, patches, sprays, and tablets, in which you can see these two are well-known pharmacological intervention which are meant for short use: bupropion and varenicline. Varenicline. So you can go for NRT, like nicotine replacement therapy. So there are brand names of nicotine gums includes Nicorette, 2 mg tablet, Nicotex, Nicogum, and Eucomint. Alternative therapy such as yoga, herbal products, acupuncture, massage therapy, behavior therapy, and some people have been able to find the motivation to quit just by calculating how much money they will save. Nicotine vaccines are also a new approach, but they are still under investigation. Then you can also make use of e-cigarettes. Electronic cigarettes are mainly, these are battery operated, and they vaporize a liquid solution which contains propylene glycol or glycerin, in which nicotine may be dissolved. So it delivers nicotine through vapors. And whereas no such studies are found in which which shows there are vapors generated from e-cigarettes, they do not contain toxic substance. So here is the short table in which you can see the parameters and their effects and the effects of smoking. So here's the conclusion. Coming to the conclusion, it is clear that smokers present with periodontitis at an early age, difficult. It is very difficult to treat them with conventional therapy. So smokers also continue to have progressive or recurrence of periodontitis, which leads to ultimately tooth loss. The opportunity for dentists to become more active in evaluation of tobacco use by patients and more aggressive in offering counseling and cessation services can impact both oral and general health of dental patients. Thank you.